Sorry.
All right. Well, thank you for that. Pleased to be here.
I gotta say it.
Yeah.
Thanks.
Okay.
I'll sit over there.
Yeah. All right. So isn't it great to be in person again? My gosh. Yay. Finally. Yeah. I'm just sick of those Zooms. Good Lord. Because what happened is that as we came back in person, the Zooms didn't go away. So now we have Zooms plus in person. And in fact, we have it right now. I just found out that, and you should be aware of this, Bob. You see that camera over there?
Yeah.
It's being live streamed to 700 patients online.
Oh, wow.
My gosh. And
Now
I was like,
nervous.
oh my
I'm
gosh.
nervous.
So this is Dr. Robert Vescio, otherwise known as Bob, who works at the hospital just across the street, Cedars Sinai. And he is the myeloma specialist there and has been for a lot of years. How many years now, Bob? 20?
20, yeah.
Around 20 years. And
Plus
so
or minus.
he is definitely a myeloma expert. It started off where he was an expert in stem cell, well, bone marrow and then stem cell transplant. And obviously he recently specializing in CAR T therapy, which is available here, and the bispecifics, all of the different immune therapies. And also Bob has specialized a little bit in amyloidosis, which is a big area as well that he's very much involved with. So please please welcome Bob. And so we are here to get things started by having you bring up your favorite question or a question that's been on your mind for a while that maybe you can get a couple of opinions or maybe the same opinion. We see actually it tends to be a similar opinion.
Yeah, fortunately.
Yes. Oh, by the way, I'm just looking over, and we should welcome them as well. I'm looking over to the table to my right here, and we do have the speakers for our program tomorrow. So I'd like to welcome them if we can. We have to the right, we have Dr. Daryl Tan, who is from Singapore. And then we have Dr. Nupur Raj, who is from Boston, from the, yeah. And then we have Rafat Abanar from University of Indiana. And then we have Donna Camarano from, all right. So she will be speaking this afternoon, so you'll be hearing from her. I was just meeting her. I mean, we did so many Zooms over the past 2 or 3 years, but finally we're actually meeting and able to talk. Okay, so one other thing that crossed my mind that's actually helpful for us before we start is, and Yellock touched on it, it's helpful to know how long have you had myeloma? And so I thought it'd be good to start just how many patients here have just been recently diagnosed within the last 6 months? How many patients have just been recently diagnosed? Maybe one, maybe a couple, not too many. How many in the last couple of years? A few. All right, so how about within the last 5 years? Okay, a few more. How about people who had myeloma for 10 years? Look at this. All right. Quite a lot of patients have had myeloma. That's fantastic. And so how about we'll go out to 15 years? How many? We have, okay, 1 or 2. All right, yeah. And then how about 20 years? Yeah. Is there anyone I haven't mentioned yet? Besides Yellock, of course. Yeah. All right. 25, yay. And how many now? 20. Hey,
That's awesome.
all right. So mostly patients who should know a bit about myeloma, actually. And so we can expect some serious questions here, Bob.
Yeah.
So, so who would like to go first?
To you. Questions? In the back?
Hi, my name is Mike. My mom was diagnosed with multiple myeloma in November of 2021. I'm here for her. She's not here, but when she was diagnosed, she got the treatment, Tumab and something. And she's in remission, thank God. But the issue is she had ITP for 20 years and she was taking medication and her platelet level was good. But it keeps, ever since she was taken off her medication and her platelets started going down. Then when she got back on her medication, it didn't work. She did IVIG. She's done many things. Nothing's worked. Only the IVIG has worked, and her platelets, no matter what she does, doesn't go back up. We've been to the emergency room so many times over the last year because they've given transplants and it goes up and then it comes down. It's been a struggle. She's doing okay right now, but it keeps, like, she gets it. It's like 40,
Right.
then it goes down to 14 and so forth every week and so forth. So I just want to know, is there anybody else here, or do you guys know of a similar situation where, where I think it's because of the chemo she got or something? Is there any hope, or what could she do? Does anybody else have the same issue?
Yeah. So I don't know if you want to comment on that. Yeah.
That's an unusual but tough one, of course. So to start off with that, I'm a little nervous. The drugs make the counts low. So
Right.
if she's still taking the medicine, that's going to add to low platelet counts no matter what. But I've had a couple people where the drugs that we use, there's an oral one that helps support the platelet counts, and I've given that along with treatment for the multiple myeloma with success. Although I would say no one was quite as had counts in the 14s or needing transfusions and ER visits. But sometimes you have to treat both things at once. But that is that's a very unique and challenging situation. You sometimes have to treat both things together, knowing that the treatment for one can influence the treatment for the other.
Right. Yeah, makes it tricky. So the low blood counts, one thing that can happen is that in addition to myeloma, you can have an underlying problem with the bone marrow, with myelodysplastic syndrome or something like that. And so it might be worth doing some double check to make sure that if there is an underlying problem with the bone marrow cells, myelodysplastic syndrome. So it'd be good to get an opinion about that, which can be checked. Yeah. Okay.
Hi, my name is Len. I'm a patient actually of Dr. Vescio's. I did a stem cell transplant in 2021 and didn't really work. And Dr. Vescio recommended a trial, which I'm very thankful to him for doing that. And I went on a trial with Nadodotin, which was just approved on Monday. After the first month, went into complete remission. It's been now just over a year and a half. They took me off the drug at the beginning of this year, and thank God everything is still holding. Question is, we were in a discussion on Wednesday with a doctor from Utah, I believe he was, and he was quite amazed to hear that they'd taken me off the drug altogether. And I just wanted to know your opinion on that, on coming off it altogether.
Yeah.
Well, I want to add, since we have others here too, we can get, this is kind of where we're all learning from each other. I mean, this is the questions that come up. I have many people who are doing well. I have a similar patient who stopped because he was basically tired of coming in. He could have continued, but it'd been a couple of years. He's been in remission for 18 of those months. And he's just tired of coming in every 2 weeks is what he was doing at the end. So he's been off a few months and counting. So I think that's the issue with all these, the CAR T cells just go in and then you're done. But with the bispecifics, often when you discuss them with a patient, then the question is, well, when can I stop? And the typical answer is you don't. But there is some debate and there is some thoughts that you can hold it, maybe allow the immune system to recover and kind of reset. And then if it's done again, it often can work again. But I think it's, to my knowledge, it's very anecdotal unless someone else has some more, more than anecdotal experience.
Yeah, maybe a couple of people could comment. I mean, just to be clear, the numbers are stable, right?
He's in remission.
Yeah, so, and that's been for how long off treatment?
Yeah.
But it went
Yeah.
into total remission after the first treatment
Right.
already in January of last year.
Right. So I think 2, 3 comments, and then we can get the experience. But definitely, there is experience that patients are coming off therapy because of side effects. Infections, in particular, are a big problem, and other reasons. And increasingly, there are patient reports that patients are actually remaining stable off therapy. And so I think that we seriously need to look at, and with some of the bispecifics, there are new protocols looking at time-constrained duration of therapy. But the main thing is that right now it's safe, and I think it's okay. I've heard reports of patients now off therapy. Well, Sadhu Usmani, who was the primary researcher for Teclistamab, he always tells the case of, I don't know how long this patient's been off therapy in remission. It's at least a couple of years now and doing well. So Rafat, looks like you have a patient like that, or maybe several.
Approval of the drug is about 150 patients. Okay, so we don't have a large number, experience. So we are learning as we go. So that's really the most important thing. So the second thing is that the science behind bispecific is amazing, isn't it? I mean, you put your immune cells next to the myeloma cells, and the immune cells get angry and destroy the myeloma. Now, if your myeloma is not there, the T cells are not going to be too angry. But long-term side effect of infection is serious, and I think that's why there are a lot of trials now looking at like you heard from Dr. Durie, is that we stop therapy. So if you are really in complete remission and MRD negative in the bone marrow, it doesn't make sense to me to continue therapy. That is very expensive and may lead to other side effects. So I'm actually practicing that right now, and if anybody told me I'm wrong, prove me otherwise. So I think it's very important that we honor the patient wishes and not scare the patients, as long as we monitoring them carefully.
Yeah. All right.
No, I agree. Obviously, the bispecifics are a new class of antibodies, and we are seeing MRD negative disease, like in your case, within a month, which is pretty amazing.
Right.
What we don't know is, when do we stop these treatments? And as Brian has already pointed out, we are now doing fixed duration approaches with these. So giving it for a certain length of time and then stopping and watching people off, specifically the ones who are like yourself, who are in a complete remission or MRD negative disease. So I totally agree with Bob for having done that.
All right. Let's have another question. So hopefully that was helpful. All right. Okay.
Hi, thank you. Tom Sparks. I am non-secretary, so all I'd like to know is what progress is made, if any, in terms of identifying myeloma that doesn't secrete the markers.
He's non-secretory.
All
So the
right.
question is how, is there any progress on basically monitoring it, knowing? what to
Right,
do?
right. Yeah, well, we'll talk about that this afternoon. Now, with the new testing, it's very rare for someone to be completely non-secretory. So using mass spectrometry, the very, very sensitive blood test, to pick up a low level of the myeloma protein, we find that virtually every patient has a little bit of protein that we can measure. And so I'm going to talk about that as this new sensitive method, the mass spectrometry, is introduced within the coming year. Then you actually will be able to monitor your protein level using mass spectrometry. And even in the meantime, I don't know where you're getting your care, but a sample could be sent to several places actually, but it could be sent to the Mayo Clinic in Rochester, Minnesota, and they could measure your protein level. Probably, they'd probably be able to pick it up using mass spectrometry. Yeah.
Dr. Durie, Michael's been oligo non-secretory for 23 years now. And so free light test is amazing for him,
Yeah.
plus PET scan.
Right.
And so maybe you can chat with Michael later and compare notes.
Right. Absolutely. But obviously, the additional thing is that in patients like you over the years, it puts pressure on us to do other testing, to do
Absolutely.
like a PET scan and other things. Yeah.
Yeah, and I think that I have a few people that despite, maybe because they were treated and they were non-secretory back then with the tools that we had back then, and then now they're doing well. So now whatever even if they had a tiny protein that I could have seen 5 years ago, I can't see it now. So now I can't find anything even with the Mayo Clinic test. And so we're basically I'm hyper aware if they have a symptom to look for signs of the myeloma growing back. And we do PET scans or total bone MRIs as a intermittent screening, although, insurance companies don't seem to, it requires like 3 phone calls and a few
Yeah, I know. That's a problem.
discussions on the phone. But that's what we do. And that works well. It's just cumbersome. And then, of course, the question is, well, how often? And then it's, I've been doing it for 8 years. Do I still need to do it the 9th year? So it's an imperfect thing. If there was another tool, that would be very helpful. People are looking at circulating BCMA as a measurement. I'm not sure that's good enough to not do the other tests. So hopefully things keep getting better, but screening with surveys is often what's done. That's
Right.
the typical.
Yeah, I think we need to do more work on reimbursement for PET CT to use it for like annual monitoring, or even more importantly. So PET CT was actually approved. The IMF actually had an initiative with Medicare, CMS Medicare, where we went to get the original approval for PET CT for myeloma, which is like, I don't know, 20 years ago
That was a
now.
while ago, yeah.
So it got approved. However, Medicare CMS are pretty crafty. They said, okay, yes, but then, under certain circumstances, you can get a follow-up, and then, it's pretty tricky to get regular monitoring using it. And so it's been very difficult to use it in a way that we think is best for patients. But it's a bigger issue now, because with all of the new therapies, patients are living longer, and we're monitoring them with all these new therapies with CAR T and bispecifics, and these patients are non-secretory, and you need CT to see what's going on. Okay.
Hi, I'm curious about the current state of insurance covering CAR T. Are you guys seeing insurance cover it? And what do you think the trend's going to be in the future?
Yeah, that's a great question. Fortunately, and kind of surprisingly to me, it's covered very well. I rarely, actually, can't recall a person being denied doing a CAR T unless I tried to do it, a little earlier than the label says I have to wait. So at the moment, you have to have had 4 prior treatments. And then it tends to get approved without much issue whatsoever. Even kind of, to be blunt, even kind of stingy insurance companies kind of succumb to the fact that it's the FDA approved for exactly what I'm using it for, and so they say it's okay. It's just, we all know it may be something you could do earlier. Why do you have to wait till then? And there are studies looking at that and have been done for that. And right now, those, I haven't really tried very hard, but those.
Yeah, it's all pretty surprising, so for a PET CT scan, which costs maybe $1,000 or $2,000, very difficult, very difficult. A CAR T treatment, which costs hundreds of thousands of dollars, no problem. Okay, that's okay. It's just quite puzzling.
It is weird.
I was diagnosed this year, and my hematologist says, well, you're not going to die from this, so we're doing nothing. Is that logical?
Well, that's a loaded question, but yeah. Well, the people are continuing to do better, as you've heard from people in the audience who've had this for 20 years. I just came to rush. I was a little late, or just got, the lady I saw, it's been 19 years and counting. When you just talk about kids and their issues. But it depends a lot on the type. There are types of multiple myeloma that smolder. And so they have the official name as multiple myeloma, yet they are not causing problems. And so then treatment isn't necessarily always indicated. But if the multiple myeloma is causing harm, then generally it needs to be treated because it'll cause more harm if you don't. Is that right? That answer?
Yeah, I'm going to talk about this actually today as well. I mean, if you want to do the best job in treating myeloma, the best idea is to start as early as possible. And so it's a fine line to start the treatment early to do a good job. And then we don't want to treat a patient who's actually okay and doesn't need treatment. So that's the fine line and I'm going to talk about where we are with testing, where you can have testing that would indicate there's a likelihood of trouble within the next year or two. And then you can make the case to jump in with earlier treatment. Okay, I think there's one back here.
Right here, number 3.
Oh, I'm sorry. It's very hard to see with the lights.
Hi,
I need to put my sunglasses on.
I love the optimism of someone actually hearing the news that they're not going to die from this. We all need some hope. We all need some optimism. My question really centers on CAR T therapy. How wonderful that so many centers are doing it. And of course, we have several that are now available. But is there a way for us as patients who might at some point be able to access that therapy to evaluate the different centers, not just the 2 types, but who's really doing well? And then maybe some speculation of why, as I understand it, centers seem to have fairly different outcomes.
Right. I think this would help. So one of the initiatives for the IMF through the IMWG, through the working group, Dr. Tom Martin up in San Francisco has established the immune therapy registry, where he's actually gathering up all of the outcomes data for patients getting CAR T therapy and with the bispecifics. And rapidly, it's more therapies. Just this week, like 2 new bispecifics got approved, Talquetamab and Lantamab. And so the idea is to track the responses, the side effects, and also to try to get a handle on the sequencing. If, for example, and this was happening these last couple of years, if there's a delay in getting CAR T cell therapy, is it okay to take one of the other immune therapies? Will that be a negative for the use of the CAR T later? So I don't know what you're thinking on that is, yeah.
Well, I think that's another question because they're all new. We do have questions of which one to do first. I think, and I don't know if there's a right answer for everyone. That's the first question is there a way of identifying centers that are better than others? And
we don't want to get into that.
No, I know. Well, and I'm going to get into it. Like I believe that the centers that are in the LA area, and I know outside the LA area, are very good and can do them equally excellently, if that's the word. So I do not. I've had patients who their insurance says, even though I've been taking care of them at Cedars, that their insurance won't let me do a transplant at Cedars. I have no worries about doing an autologous, having them go to UCLA or City of Hope or USC for an autologous transplant. I think we can. We've gone past to where I think a center that's done more than a few, 10 of them or more, they can do a CAR T cell well. The question is which one. That's another question because we have two. And then the timing, but I wouldn't really. I think you should go to a place you feel comfortable with. It's convenient, right. And then the person that you interact with. If you get two opinions, the one that you interact with the best and feel like they mesh with you the best. If you're the one doing it.
No, I fully agree, and I think that what Bob has said is certainly true in the Los Angeles area. But I'm sure the review and approval to set up CAR T centers is fairly rigorous. And so I think that you can feel pretty comfortable if a center has been approved to do CAR T therapy, especially right now, that center has probably gone through pretty careful setup process. And so I don't think that's the issue. I mean, no, I think CAR T is more accessible. I think that now the big problem the last 2 years is that you were on a waiting list and it made it very difficult. But I think that now it's mostly eased up and it's not so bad. I don't know if Nupur, in fact, you want to comment on availability so you can have some flexibility. Yeah.
We have 2 CAR products approved. We don't have the long wait lines anymore, Brian. And now that we have the 2 bispecifics also, if your myeloma needs to be treated, I wouldn't necessarily keep waiting for the CAR T cells, use the bispecific. The question which Bob alluded to, which one comes first and which one how do we sequence this? I don't think we know that as yet, but over the next couple of years, I'm sure we're going to be able to figure that one out.
Right. Darryl, I don't know if you want to comment on this, but I mean, we are pretty spoiled here in the US. Maybe you could comment on what would happen with a patient in Asia, wanting to get CAR T therapy, yeah?
So first of all, maybe I can comment on the situation in Singapore. So we're only expecting our approval of the commercial CAR T and bispecific towards the end of the year. So far, we've only done academic CAR Ts. So I wouldn't say that I've got a lot of experience with CAR T or bispecifics. And bispecifics, we can lay hands on compassionate doses, named patient basis. So this is as far as the experiences we're getting in Singapore. But for the rest of Asia, for the most part, I mean, CAR T, we're still awaiting CAR T approval for the rest of Asia. So certainly this area is certainly lagging behind compared to the States.
Right. Okay. Right.
Oh, hi. My name's Jonathan Lamb. So my dad has relapsed refractory multiple myeloma. Quite an aggressive form. I think he has those translocations and the chromosome 1, 14. And he's in the UK. So NHS, he's at he's seen quite a prominent hospital at Royal Marsden. but he's
Good one.
relapsed every 6 months. So he's on fourth line therapy right now, pomalidomide and Dex. According to our NICE guidelines, the next treatment would be Belantamab Nadodotin. So the GSK drugs. In the US, I believe that there was a safety concern with that. But in the UK, that's the next line of treatment. I just want to know, what was the experience here in the US? Is there something he should be concerned about? He might be using that in a clinical trial, so in combination with other drugs. So I wanted to know opinions.
Right. These are certainly complicated issues there.
Yeah, I've had a fair amount of experience with the drug. I have one person getting it now because it's the only drug that worked for him, including a transplant and everything else. He had amyloidosis, needed a heart transplant, and so to keep his amyloidosis in remission as it crept up, the Belantamab got him in remission, so he could have a heart transplant, and then it's creeped up a year or two later, and now he's back on it. So the big issue, it's very well tolerated physically, but it does irritate the eyes, and that is very annoying. And a couple times for him, he got it when we thought it would be okay to give it, and then he had blurry visions for a while. So I don't think I think these other drugs that we have available in the United States are, I would say, superior for the great majority of people. I would be bold enough to say that, but it does work, and it just, there's a whole routine. They have to have an eye doctor check the surface of the eye, because that's where the drug does the damage. And the other side effects are relatively easy to control. I personally never had anybody. He's been the biggest success story from it. And sometimes you never know. I mean, we all have percentages, like, okay, well, this drug works 60% of the time, that works 30, but somebody is one, it doesn't mean it's going to work 60% of the time. It just means your odds are better. So sometimes you get lucky, like it did for him.
Right.
So hopefully your dad will be lucky too.
But you can't start new patients right now in the US.
No, you cannot. Right. You cannot start new patients in
the US, but outside the US. Yeah,
you can. I don't even know.
Compassionate.
But the problem is the ocular toxicity, the damage to the cornea. So it's very serious. I think the major problem is that we think about it as a drug that we need to use it as frequently as the companies initially said, every 3 weeks. And I think that's the major mistake, that they really get themselves in trouble. So I don't know how they're going to use it in the UK, but I know that the company trying to test it in a different schedule.
Absolutely.
And that's really important, because, I had patients who were ready to go on hospice, and, we give them a dose, and we couldn't give them the second dose. And then 3 months later, get the second dose, and they still around 2 years later. So it is a good drug. The problem is that the way the schedule was wrong.
Exactly.
And I think that's the major issue.
Yeah, it very much falls into what we were talking about with the bispecifics. It seems like, as you mentioned, patients who have a good response, they can have a response that lasts for some time.
Mm-hmm.
And you don't need to keep giving it.
And that it did not come off of the market for toxicity issues. There is toxicity, sure, but we do know how to manage it. We give it every 4 weeks or every 8 weeks with the IMiDs, and it works extremely well. The reason it was taken off by the off market by the FDA, I think, was a little bit premature. The confirmatory study did not meet its statistical endpoint. There are ongoing clinical trials, and we hope that it will come back, because honestly, given that we have bispecifics, we have CAR T cells, this is probably a very easy drug to use, and most patients tolerate it. And so it wasn't a toxicity signal. I just want you to understand.
Yeah.
So your dad will do fine with it.
Yeah, it's a very, very important point. And unfortunately, a very firm statistical endpoint had been established, and they missed the endpoint by 0.001. you know, it was kind of like, okay, that's the endpoint. Oh, you didn't make it. You're like 0.001 off. It's like, oh my God. And so I think that I think it is a good drug, and I think like the others, we just need to learn better how to use it.
Yeah.
All right.
Number 3, right back here.
Yes, I had a question. At what age do you think you would stop giving a patient chemotherapy, or, you know, have them taking the
Stop
drug
using
for
chemotherapy?
myeloma? My mom's gonna be 99 next month.
When would you stop giving treatment, chemotherapy, and her mom is 99 next month?
Oh,
And so I don't know how old the patients are that you have treated, if she might be one of the oldest ones, but
yeah.
I was just curious about that, because she
Yeah.
takes Revlimid, and she usually stays with my sister,
Right.
but they had her take Navestin. I guess something might have changed, but I was just curious about that. At what age?
Yeah. It's a yes. I mean, there's no reason not to.
Yeah, good question. What does she want?
That's just true.
Yeah.
If,
Yeah, I thought, you know, 99, that would be around. I mean, I was about to tell you somebody would once is going to be 96 and he takes Ixazomib as his sole therapy and it worked. That's what put him in remission. And has no side effects. So there's no reason to stop. So I think if there's no side effects,
right,
and it's working, it's the old, if it's not broken, don't fix it. But it's a personal decision, certainly. Yeah.
Yeah, I think the personal thing is the most important, but we have several drugs and combinations that work really well, like what we call the Maya regimen, the daratumumab Revlimid. It works really well in older patients with some dose modification. In fact, the Queen of England, Queen Elizabeth, the story is that she actually had myeloma and was getting treatment. So as you know, she died, you know, right before 100. So I think that the key question is, what does she want to do? Does she want to go to Florida and play shuffleboard, or I don't know. What is in her game plan? But I think that there is a treatment that could be offered. By the way, there is a clock in front of me that is whirring away.
Yeah,
I don't know
sure
what it's doing. Are these the numbers of minutes that we have left, or no? What is that?
Oh, wait, what time is it? Oh, you have plenty of time, right? So your don't look at those numbers. Don't worry.
Yeah, so, yeah.
Wrong data. Wrong data.
Wrong data. Okay, good.
Questions? Oh, Jonathan?
Hi there. I see a local oncologist. He's not a myeloma specialist. And I'm just wondering, they tend to defer to the NCCN guidelines for myeloma care. How long does it take for guidelines like from the IMWG to move those new guidelines to NCCN, or is there even a correlation between those two?
Right. So, yeah, there's definitely an issue about the timing of guidelines. And I have to, I'll apologize on the part of the IMWG, is that our relapse guidelines, which were published with Philippe Moreau from France just in the last year, he worked on those for like 5 years. It did take a while. There are so many relapse therapies that he wanted to do a good job. And so there was a little bit of a delay. And so I think that there is something that we call standard of care. And so to meet what we call standard of care, then that requires at least 2 studies that confirm that the treatment is working well. Now there's NCCN, which actually kind of puts everything on the list. With the idea that if something works, they want to make it available, right?
Ten Commandment. It's a guidelines, guide you to a treatment. And so the good news about that the NCCN guidelines is that gives the physician the possibility to give the right treatment for the right patient, because you're not all created equal. You all have comorbidity. You have other diseases. So combination A is not going to work for everybody, and combination B will work for some. So that's a good thing about the guidelines. So I think it's the options available for patients. That's what these guidelines.
So I don't know if you want to comment, Bob. I mean, frankly, when we're looking to give a therapy, the NCCN guidelines are helpful because usually everything's on there, right?
Right.
So then you can gives you some flexibility.
And that, fortunately for myeloma, I'm happy with how the NCCN guidelines are generally made because they aren't very restrictive. But still, there's occasional times like somebody where it says, okay, the next treatment you have to give this drug with, let's say, Velcade and dexamethasone, and then the patient already has had side effects from the Velcade, but the other two drugs they've never had before. So then my pharmacists read the NCCN guidelines, and that's what they figure is gospel. And so then they see that and they go, wait, you have to give Velcade with this. And I got to say, well,
right, and
so on and so forth. So it is a guideline. It's not a rule. It's not a law. So that's what, but sometimes you have to intervene with the insurance companies or whoever approves it or whatever to point that out to them. And they often do view it as a rule, unfortunately.
Right. But this interaction with the insurance company is the most important thing in terms of being able to get access. The IMWG guidelines mostly relate to the scientific evidence that is the background for designing a next trial. When you want to have a trial where someone has what we call failed, or as we say, the treatment actually failed them. But anyway, where the treatment didn't work, you need to have a precise definition where you're designing a trial where someone has taken Revlimid, for example, and that has ultimately not worked. So it's more about having precision within the clinical trial experience. All right.
I have a question about IVIG. It was recently recommended to me by my oncologist, and he said that until recently it wasn't available for myeloma patients, but now it is. Because of a supply issue.
Yes.
And what is the typical duration for treatment? What are the metrics for success? What do you look at to see that it's working? And
so IVIG has hit the big time. It's recommended now for supportive care with the bispecifics. We were talking about it earlier with teclistamab, and the big problem, if you keep taking teclistamab, the bispecific anti-BCMA bispecific, which is now commercially available, and Bob, you were saying you've got like 25 patients on that now. As patients keep taking it, they run into infections, including pneumonia, and so the intravenous gamma globulin, IVIG, is recommended as a way to reduce that problem. So, are you using that?
Yeah, I try not to. I consider it part for those drugs, the CAR T cells and the teclistamab. I use them kind of concurrently. I figure they need to go together. The thing with sometimes with the CAR T, as an example, the treatment goes in, the patient responds, and then their immune system recovers. And then you can start, okay, you see their immunoglobulin, their IgG level, because that's all we can replace. We can't fix an IgA that's low. Doesn't seem to be as important though. But if the IgG level is coming up each time you give it, then maybe they can do without it. And so then the question is, you do it less often or you just stop and see. But I think it's a very important part of treatment for patients on the bispecifics and CAR T, at least for when their immune system suppressed. And for others as well, it's been around. It just isn't always used in the.
Right, we didn't, for all these years, 20, 30 years, it's been around, but we haven't used it related to the prior therapies for myeloma. Even with the monoclonal antibodies like daratumumab, we didn't really need to use IVIG, but now it's become really pretty important.
To answer the question about the metric, so a lot of patients are IgG myeloma, okay? So when you're looking at the total IgG level in your blood, unless you're in remission, that is a combination of normal IgG and myeloma IgG. So a good doctor will pay attention to that and will tell you that your normal IgG is that level. And if it's below 400, it makes sense to be on IVIG. But if it's above 400, you probably can back off, as Bob said. You don't have to take it every month. You can do it every 2 months. But that's really the most important thing, is that people don't pay attention to that. When the total IgG is measuring both the myeloma and the normal IgG. So you have to do some subtraction. It's not easy to do the subtraction because they give you the myeloma protein level by a different unit.
Right.
So you have to do the conversion, and then you do IgG minus the myeloma IgG, and that will give you the normal.
Right.
And so that's very important.
The problem is, again, this is where you just have to be persistent, because one has to convince an insurance company or whoever the payer that clear understanding of what we're measuring, and they don't, they often are more checkbox, not to be mean, but they're checkbox oriented. Like, is the IgG below 400? No, okay, it's not accepted. So that's where you need you and your doctor to be a little more pushy.
Yeah.
CAR T was just having more infections I normally wouldn't have. Like waking up and having, I felt like I needed a tonsillectomy, got antibiotics, took care of it, and it's happened twice. So
it's useful even before, without the CAR T. I have people doing it that, we're on the daratumumab or even before that. Yeah.
But it is massively expensive, and the insurance companies are doing their job to try to manage that, because I don't know what it's, how many thousands of dollars is it?
I don't want to know. Yeah.
It's pretty expensive. And so, this is going to become a more crucial issue in the next 2, 3, 4, 5 years, I think, because with these immune therapies, there's a cost to the immune therapies. It costs money to prepare the CAR T and to prepare these bispecifics. But what we call the supportive care is also hugely expensive. And that's another reason to limit the duration of the therapy, because it limits the duration of what is very, very expensive supportive care. All right.
Over here, Dr. Durie.
Okay.
All right. I'm not the patient. My daughter is 57 years old, and actually should be 57 in November. She's a 15-year survivor, and she's on this
Did you hear?
Pomalyst.
Her daughters are 50. I'm on the list.
Uh-huh.
We're having a hard time hearing up here.
Yeah, but you're on Pomalyst and your numbers came down.
It's my daughter.
Oh, your daughter, sorry.
Yes, she's not here. She's 57 years old. And
57 years old.
She's on this Pomalyst. Yes, she's a 15-year survivor. And she does everything, you would never know that she was diagnosed. So I was just asking about the drug, as you were discussing the drugs. Is that up to date? She started out with what was it, Revlimid or something?
Revlimid, first on Revlimid.
Right, but she's had 2 transplants at City of Hope in Los Angeles.
There's better stuff out
He still can't hear. Can you hear me?
Is the question is that should she continue on the Pomalyst or should she try one of these new drugs that just
Yeah.
got?
Yeah, that's what we're thinking, yeah.
Well, you go for it. My first thing is the new, I'm gonna, if something, the same thing, if it's not broken, don't fix it. So if she's doing well, it's been 15 years, there are people that have been 15 years or longer or on Revlimid, and that's even earlier than Pomalyst. So if it's working, you don't change it. But if there's side effects or it's not working, then now you know there's a lot of other very good options that have a good chance of working.
Right, yeah. This is a very, very good model. In fact, when the arms were raised to show people who are alive the longest in this room, at least a couple have been taking Revlimid for most of that time. So sticking with what is working can really do a good job.
Yeah, she was on that at first. The Revenant.
And so, yeah, the good thing is to be aware there are all these exciting things available. But what we've been talking about is that they can come at a cost, both in terms of side effects and financial.
Okay.
Okay, more questions?
All right. This lady right here. Hello.
Hi. Is it necessary to start or continue with the bone density drugs if you have no bone involvement? I mean, just because of the future or something, or, I mean.
I will have to say the questions here are very good. Yeah, no, that's another one of those questions. So back decades ago, the drugs for the bones, when before there weren't any, there was a randomized trial where they flipped a coin and people got a drug before Zometa. It was called Iridia or Pomidronate. And back then, people with myeloma weren't doing so well. And a lot of people had broken bones, and everyone was just thankful there was something, and it seemed to help. And the studies went for 2 years, and then you had to end the study at some point and analyze the results. So that's what happened. So then new drugs come out.
Vescio was actually involved with those studies.
So then, so now, as you're seeing, well, 2 years is one thing. What about 20? And so that's the issue. And I'm not sure, to my knowledge, I don't know myself that there is any kind of good, okay, you can stop now, you don't stop now direction that can tell us. It's a more common sense thing. And that I think it needs to be kind of individualized. The drugs do have some anti-cancer effects. They're modest, but they do have them. So some physicians, especially in the local area, kind of focus on that. And there is some truth to that, but they also have toxicity that does build up the longer people take them. So it's a balance, if you have pristine teeth, because it's ONJ is one of the worries, then and bones were really damaged by the myeloma and the myeloma is not in remission, maybe you should take it longer. If the teeth are less good and the myeloma has been in remission for a while, then maybe the risk of having the complication is greater. They also maybe make the bones a little brittle, and that's a little harder to assess. And then we have bone density tests that you can use to get somewhat of an idea how the bones are. But I don't really, other than that, I don't personally know, it's a very individualized thing on what to do.
I think the question that you asked is a really good question, though. If you don't have bone disease to begin with, the recommendation is if you're being treated for symptomatic multiple myeloma, we would use a bone targeted agent with that. I think the frequency of how often you use that bone targeted agent after that initial treatment can be cut back. The one thing which we sort of underestimate is when patients are getting anti-myeloma therapy, such as steroids, which is part of every treatment, we do cause some osteopenia, osteoporosis. So you don't have to get the monthly treatment that we used to be giving for the 2 years, but almost get treated as if you have osteoporosis. And, that could be once a year if it's zoledronic acid. It could be twice a year if you're using something like denosumab. But in general, we do continue using these bone-targeted agents, albeit at a lower frequency based on whether or not you have bone disease.
Right. So those kinds of drugs, the bisphosphonates and others, they're recommended for people who don't have myeloma, people who have osteoporosis and other issues. And so the frequency on that is usually like once a year.
Right.
And so you can revert to that as a minimum. But the second point is, because we have so many very active therapies now, we can see right in the room here. I'm thinking back to 20 years ago where, so many patients were coming into the room with wheelchairs and with crutches and things like that because they had so many bone issues. So we just don't see that anymore because the myeloma is brought under control.
And more quickly.
And in a sustained way. And obviously, when patients relapse, they may have some new bone issues, but then at that moment, the bone therapy can be restarted. So anyway, the summary for me is that I stop the treatment, mostly.
Yeah.
Okay, we've got another question over here, Dr. Durie.
Thank you. So, question about MRD negativity. Are there any studies going on right now about using that as a trigger for coming off treatment? I mean, we're never going to have a drug company that's going to be testing to see when you should come off their treatment, right? So maybe using MRD negativity as the trigger.
Right. Stop the treatment.
I don't know all. I know there is a large one in the United States after a transplant where if patients after a couple of years, if they are MRD negative, then some treatment will be stopped in a randomized way.
Right.
So that's one way of addressing the problem. I mean, it is. This is where we're going to probably have different viewpoints, but I kind of view the MRD testing as very important to help guide what therapy is better than another when you're doing a study.
Right.
Because if you have a study of 300 people taking one regimen and 300 people taking another regimen, you kind of want to learn quickly, is one treatment more profoundly effective at killing the myeloma than the other? And you don't want to wait till something like survival, because that fortunately takes a really, really long time. So you can use that as another key indicator. But I personally am not, my view may be different than everyone else's, but I don't use MRD negativity. And I'm going to be one that's going to have to be convinced to use MRD negativity as a reason to stop treatment, because I certainly have seen people negative relapse. And I've certainly seen people who were never MRD negative live 20 years with a disease. And the other thing is, if something worked and got you to MRD negative, then this goes back to the if it's not broken, don't fix it thing. So I'm not sure. I'm going to be the hard to convince guy to stop it if you're MRD negative. But some people having side effects. That's another way of like, well, there's side effects of the treatment, and you're now MRD negative. That sounds nice. Maybe we can back off on the therapy. But it's a hard one. Yeah.
We're in agreement.
Yeah. Okay. Oh, good.
We're in agreement that staying on therapy, even if you happen to have had a fantastic response, is a good idea. As I said earlier, I mean, patients who have done that are actually doing great here, right in the room. And so we don't, on the flip side, there is a Spanish study, a GEM study, where it looked at stopping versus continuing. And continuing, it did push a percentage of patients into MRD negative, when they were randomized. But that's actually a different question.
Yeah.
So it's in clinical trials that it's valuable. And we have a project with the FDA where we're proposing MRD negative is an important, what we call a surrogate, to use to show that one treatment is better than another. As you can imagine, if one treatment has a higher percentage of patients that become MRD negative, that would be a better treatment. But you need a lot of data even to kind of prove that point, which is what we're trying to do right at the minute.
I'll just add one
Yes.
more thing to that, because your question is actually very relevant, specifically when we're using all of these combinations. And the question is, when do we stop treatment? I don't think we know that. What we do know, though, is just a one-off MRD testing is probably not enough for us to stop. So the IMWG and the societies have come together and come up with a definition, and we call that sustained MRD negativity. So you have 2 MRD tests a year apart. And if you're negative at both of those tests, the chances of you having a really deep, deep response is great. And that's where thinking about stopping drugs is definitely a good idea. There was a trial done in the United States called the MASTER trial, which did test that. And there is a subset of patients who have standard risk disease where we can actually begin to ask the question of, can we stop drugs? And we are doing that going forward. So I do think we will be able to stop medications, especially in people who have standard risk, non-high risk disease in patients with myeloma.
Maybe. Maybe. I mean, I think that what's happened, and actually I'll show a slide about this later this afternoon, is that what's happening at this lower level, we're not seeing. I mean, if the protein is at a low level and it's below the level of detection, anything could be happening. It could be stable and we're not measuring it, or it actually could be increasing, but we're not measuring it. So I think that the introduction of mass spectrometry will actually allow us to assess what's happening at these really low levels. And we'll see if patients are actually stable at this very, very low level, or sustained MRD negative, or actually some patients are slowly increasing, which could take, 1 year or 2 years before we redetect what's going on. All right. I'm still watching this clock. It has no relevance, right?
It's hard not to see it, yeah.
Very simply, how about vitamins to keep the bones in good shape? I mean, is that a suggestion or a good idea to do?
No, this is a good point, and this has been debated back and forth. Calcium supplements, vitamin D, and actually, Bob, you worked on this. Do you want to comment? Yeah.
Well, I think it's always certainly not a harmful thing, and whereas if somebody is deficient, it can be harmful to the bones to be deficient. And so when all these studies were done with these drugs to protect the bones, a requirement was for people to be on be on vitamin D and calcium. That was a requirement. As we're kind of indoors more than we used to be 1,000 years ago, people don't get as much vitamin D, and it's important for the bone. So it's just one of those things that can be done. That's relatively easy to do. That probably people that don't even have myeloma should probably do. It's another pill, so that's the downside. And so people are like looking at their list of pills, and but I think it's a pretty benign thing to do. And we check. The reality is, if you check an Alaskan in July and then you check them in January, they might be fine in July and not so much in January with the same treatment. So it kind of depends on if you just came back from Palm Springs or not for a couple of weeks.
Right.
So I don't know. I'm not entirely sure how much the levels mean, but I think it's probably a good thing to check and make sure you're getting enough.
Right, and there is a increased frequency of low vitamin D in patients with myeloma as well. So I think it's good to check your level, I think. And then that could be a situation where it's worth at least getting your vitamin D level back in the normal range. All right.
Dr. Durie, way in the back here, we have a question.
Okay, there's a couple of questions. Okay, the gentleman at the back, yeah?
Yeah, My name is George. I want to know, do you give the patient a cure algorithm? Because my wife carry myeloma on pancreas and pelvis, and 10 years ago, and have a RVD, and 2 year, and acupuncture, herbal tea. Then, remission for 7 years. Totally 11 years remission, and she stopped the medicine 3 years ago. She want to know, do you give the patient algorithm to cure?
Give the patient what? Afterwards? They stopped the treatment 3 years ago?
Algorithm. The algorithm to cure.
Cure?
Yeah, cure.
Do you give what for?
Do you give the patient the cure?
So she stopped, she did well for 7 or 8 years at least, and then she's been off treatment for 3 years. So would you call her a cure? Is that the question?
Yeah.
Right. Okay. So we're pretty cautious about that. I think that myeloma is an unusual type of cancer where it can lie dormant for a while, and then it can rear its ugly head. And so we're very cautious about saying that the myeloma is kind of gone forever. Even when it's MRD negative, we are very, very cautious about saying, okay, it's definitely cured. It's obviously a good thing. And the good news is that what we call the biology, the pattern of the myeloma tends to persist. If someone has done well and then they stay in remission off therapy for a while, this is a good thing. They may not be cured, but this means that they have this kind of what Nupur was talking about. If they're more of a good risk patient, they may do better and also continue to respond when they're retreated. But that's different than saying that someone might be cured.
But I do think you need. I have had a bad experience with someone who thought they were cured and then decided they were cured enough to never need to be tested. And then when it grew back, which I think we would have recognized it was growing back. When it did grow back, it grew back in a bad place because no one had checked for a few years. So at least getting checkups to make sure it's still gone is important.
Very, very important to monitor, so that that's one of the things that we do more now is that we talk about starting the treatment early when you're first diagnosed. But actually, starting the treatment early when you're definitely relapsing is equally important. When you're being monitored, we want to track, see if those numbers are creeping up so that we can come in with something to make sure that it can be treated well.
But so far, her blood test better than I am. Her blood test lab better than I have. Blood work, her blood work better than I have.
Her outlook.
Her blood work is better.
Yeah, no, that's
than
great.
his.
She that's all a win.
All right.
Dr. Durie, on the other side of the room, Jonathan.
Hello. I was diagnosed in 2008 with myeloma non-secretory with IgA lambda and major bone involvement.
Non-secretory, but it's IgA lambda. Okay, that's good.
Oh, yeah. But I went to a physician, Dr. Vescio, for a consult, and one of the tumors removed from the femur had significant sheets of lambda and kappa. So he said basically it was just a determination made to say lambda instead of kappa light chain disease. Essentially, I guess I had both. Now my question is, over the years, even though I was diagnosed as a lambda, those light chains have stayed stable, but now my kappas are rising and are at 24.7 milligrams per liter. And it's been rising steadily since the beginning of the year. And I want to know the next step to take.
Okay, I think that it's hard to comment. I think that with the non-secretory story, there can be several possibilities. One, you can have like multiple clones. You can have one that's like an MGUS, and then one that's actually the active myeloma.
Right.
And it sounds like
that's what I think.
The first thing that we can say definitively is it's very, very rare for a myeloma to switch from lambda to kappa. That's very
for
rare.
sure. Yeah.
And so if you're having active kappa right now, my suspicion is that that has been the important part of the myeloma in the past as well. And it may have been confusing because it was non-secretory.
Yeah, people can have two, which and there are we have many examples of that. It's not as common, but people that are more likely to have myeloma are more likely to have another clone just like it, and but that one may not be malignant.
Right.
And so you can live with it. People have MGUS all the time. In fact, when I talk to an audience and there's 100 people, my age, and then somebody in the audience is going to have MGUS. They just don't know it. It's common enough. 4% or so of 50-year-olds and 60-year-olds will have an MGUS. They just don't know. So when people have myeloma, you're going to know because everybody's checking. And so it's important to recognize is if one is growing, then it's behaving badly and you'll eventually have to treat it. Yeah.
Yeah. You can get even 2 or 3 clones, but the important thing is it sounds like kappa is the one that you need to track now and make decisions related to that.
Okay, Dr. Durie, we're back on this side of the room.
Yeah, this lady here has had her hand up a few times.
Hi, Dr. Durie. Hi, Dr. Vescio. Good to see you both and be back with you in person. I am the CBD queen that asks you the CBD questions every year at the conferences. My mom had her transplant in 2016. After that, she was put on Dex and Velcade. She couldn't take Revlimid. It wouldn't work for her. So
how old?
70. She just turned 70 last month.
All right. Okay.
And the Velcade caused her unbearable neuropathy, the worst side effects. I mean, even chopping 1 carrot, the knife would fall out of her hand. And it was a whole process to even be able to prepare a dinner. So it took me 2 years to convince her and her doctors to allow her to take 1 drop of CBD. But I had to fight and got her on CBD and CBG. My question for you is, I saw that there were studies being done in 2016 and 2020 with the different drugs, the Dex, the Rev, the Velcade, and the benefits that CBD could help with the neuropathy. Because most people in here probably are suffering from neuropathy. And I just want to know, are those still happening? Because I haven't seen any post-COVID studies being done about it. And have you heard of anything? Because she's a whole different person since I got her on both CBD and CBG. The neuropathy is bearable. Her pain level is manageable. She's back to work and she no longer has light chain deposition disease. Her kidney function improved drastically. Her doctors are now, whatever you're doing, continue doing, please don't stop doing. So I just want to know why we're not seeing trials around that. Or are they going on and we just don't see them, the public?
Right. Neuropathy, definitely challenging. And so we do have, in fact, we used to always show the slide with the cocktail of the combinations of vitamins that we would recommend for neuropathy, which sometimes would help. But it really is very challenging to reverse established neuropathy.
Alpha lipoic acid sometimes. But I think the challenge, the CBD-like products can certainly help people with their neuropathy and make their pain better. They're just the way I haven't seen studies. I'm not aware of studies. It's more that we've had people do it and they feel better. And so you say, okay, that's good. And then some people try some different version. It's a little bit challenging for me as a doctor to know, okay, what dose, how do you do it? Us as, the way we're trained, we don't get that kind of information. So, but definitely they can help people with it that have neuropathy. And then of course, the big thing is to try to prevent the neuropathy from happening in the first place. And so there are other drugs that work like Velcade. I kind of mentioned it, the carfilzomib, and that doesn't have as much neuropathy. It's kind of a similar drug that, if you don't need it, you don't need it. But that's one of the reasons why that drug is used for myeloma is it's a little easier on the nerves, just more cumbersome.
Yeah, so we can definitely get you
The neuropathy. No, that's great. That's awesome, because it doesn't, the neuropathy from Velcade sometimes goes away even without the CBD, but many times doesn't. And I'm sure there's somebody in the audience that has it and would like it to be less. So
yeah, there are all kinds of stories. Yeah. When we've had discussions like this in the past, well, in Florida, one patient would say, well, what really helped me the most was I put a bar of soap in my bed at night, and that worked great.
Irish Spring.
And people were like, yeah, laughing. And then, so then actually a few people tried it, and apparently it can help. I have no idea.
Jonathan has a question in the back left.
Hi, hello. I wanted to just discuss the early stages of myeloma. I was diagnosed around 10 years ago with myeloma. Yep. And at the time, stem cell transplant was the popular way to go. And we harvested stem cells for that transplant. I went through the transplant, had chemo, and went into remission. And then about 2 years ago, it morphed back. And being a survivor of myeloma, a lot of us are starting to see the disease when it does come back to morph. And mine ended up morphing into leukemia. And the fact that I had harvested stem cells early in the process gave me an option to get another stem cell transplant, which for most people do not have that option to go through. And I'm back in remission again, mainly because I did the stem cell harvesting early in the process. And it's not a consideration or even a discussion with patients early in the process how potentially valuable the harvesting of stem cells can be early in the process, so that they have that potential option down the road.
Very, very good point, I think, to harvest the stem cells. I don't know if you have problems saving them now. It can be problematic to save the stem cells, but increasingly having the stem cells is available for a second transplant. But now in patients who've had all kinds of different therapies, their blood counts are low at the point of relapse later. And so using the stem cells for kind of a top up for the blood counts can be very helpful. So what's your current experience? Are you able to save these stem cells and use them for miscellaneous things later?
Yes, and I know the patient very well.
Okay.
So we're able to for a while, and unfortunately the hospital started to get a little cheap, and they would make people pay for it after 5 years. So 5 years free, and the next has to be paid for. But now it's been extended because we're coming into this issue more and more often. And so some people, you know, as you mentioned, Brian, their counts, they get other treatment and their counts decline. And now you're forced with, you don't want to treat the myeloma, but you don't have good blood counts. And it is kind of a way of restarting things. The other issue is if you get an actual acute leukemia, like the MDS that turns into AML, and that's what happened for this patient. And it worked well for him. So there was a way of kind of fixing both at the same time.
Right.
So, but I think it's not there's many people that of course don't think of and don't want to have a transplant. They figure that everything's going well, but I think having those cells is just a good thing to have in the bank, because things do change in the future, and it's a way of kind of getting you out of trouble in some cases.
Right. It's going to become a bigger issue, I think, because the same discussion is there for harvesting T cells. You were talking about CAR T therapy. When you harvest the T cells for the CAR T treatment, you're doing that later in the disease after many relapses. And so there's an argument now that early on, just like harvesting the stem cells, you could harvest the T cells and keep them for later. Yeah.
I hadn't heard. Yeah, that makes a lot of sense. That makes a lot of sense.
Yeah. So a few more calls to the insurance company.
Yeah, exactly. Yeah.
A little bit about vitamin D. Is that one of the vitamins that you have to be careful not to get too much of, or is it you can, if you just take vitamin D and you aren't going and getting your level checked all the time, it's probably not going to cause you a problem, or you need to be careful?
I think it is. I'm kind of, I think there is a toxicity to it. Vitamin A, I know. Vitamin D, I don't know. Yeah, fat soluble, yeah. But
Yeah.
yes.
No, replacement to establish normal levels is.
That's fine, but the question, can you just like overdo it and get into trouble?
I would expect that you can overdo it.
Yeah.
Yes.
Yes.
I wouldn't recommend. I think that you would just replace it to the normal range would be fine.
I think the recommended dose for vitamin D daily is 2,000 international units. And with that, you're not going to get toxicity. Vitamin D levels are not to be checked every time. They're checked every 4 to 6 months at most. And as long as your vitamin D levels are about 50, you're doing okay. And I think vitamin D is really important, especially if you're on any of these other drugs like Zometa and Xgeva. Being vitamin D replete is a good thing, but at 2,000 international units a day, you're not going to get toxic with the vitamin D.
Right. Yeah, this has been a big problem over the years. That vitamins are healthy, so taking more could be even healthier.
Right.
Maybe not. Maybe not. All right. Is this clock finally relevant? It's getting.
3 questions, and I think they're going to have to be these rapid fire questions.
Oh, rapid.
I don't know who was first. Danielle over here in the back right.
Yeah. Okay. I guess mine's a follow-up question to the person on the other side of the room regarding the light chains. So, is there a difference in the type of treatment for someone who has a light chain, relapse refractory multiple myeloma, and is more predominant in the light chain versus the paraprotein? Is it still, you still use the same drug,
same treatment, right?
Same treatment, different clones, because the clones are always changing.
The pace change maybe changes what you do. So if it's growing slowly, that may be different than if it's doubling every 2 weeks. But what it makes doesn't matter.
Right. Okay. I guess maybe a second and last question.
I've suffered for 10 years since my first Velcade. I went for, there's a treatment at UCLA, it's called Scrambler. It's an Italian machine, and it's taken away all my pain. It doesn't take away the numbness, but it takes away the pain.
Okay.
And it's a pretty simple treatment. You go for 10 of them, they put like tens, pads, that kind of thing. And it's been very effective for me. So they have this available. It's called Scrambler.
Yeah. Well, that's good to know. Thank you.
Over here.
All right, a last question here.
2 quick things. I've been using photobiomodulation, red and near infrared light, to reduce my neuropathy. It doesn't cure it, but it does reduce it. Days that I don't do it, I notice a difference. Second thing, I was diagnosed with multiple myeloma in 15, did induction and then Revlimid. 2 years ago, I was diagnosed with stage 4 HPV squamous cell throat cancer. So they had to take me off the Revlimid because my blood levels were low. I did 5-FU and cisplatin. During the biopsy, they scraped part of the bone off of the inside of my mouth, and it wasn't healing because of the Aredia and Zometa. So they waited to try to get it to heal. But I've had radiation, but the last 2 years I've been off of treatment. My blood levels have gradually returned. My heavy light chains are normal. My SPEP comes back abnormal, saying that there is myeloma protein, but it's too low to quantify. My question is, they're just continuing to monitor and periodically do PET scans. You talked about, obviously, I'm IgG kappa. You talked about my IgG levels are normal, but that there are, obviously that's malignant and non-malignant. How do I know when I should be going back on treatment?
So what, and then what's the last, what was the question at the end?
How do I know when to be going back on treatment?
So
Will you discuss
so
how
you
to
can,
determine
you
the
can
difference
see that
between-
IgG protein is there. And so then the issue is, you know, if it keeps growing, you will ultimately need treatment for the multiple myeloma, you know, that has come back. But there may not be such an urgency given everything you've been through. That's kind of a, that's a judgment type of decision. Yeah.
Right. Thank you. Yeah, but we do have some simple options and.
Yeah, and I've had people with, you know, unfortunately, you get one cancer, I've had people, they get another one. And so now they're dealing with two. And it requires a lot of, you know, work with, you know, no one wants me certainly treating lung cancer or head and neck cancer. So I have to have them see that person. So, and then we talk which one's priority. Can we do both at the same time? Daratumumab I've given at the same time with therapies like you just mentioned, because that doesn't seem to interfere. But others like you meant Revlimid, it's going to be hard to give with drugs that cause low blood counts. So, you know, you're just going to have to watch and see. And if things are growing, then you're going to ultimately need to take care of the thing that's growing.
Right,
that's the myeloma.
Yeah, fortunately, usually, you know, one takes priority and then you end up focusing on that.
Generally.
It's difficult for sure, very challenging. Okay, well, we, as Bob said, fantastic questions. We hope that we've done our best with the answers. Yeah, with help from our colleagues.
A lot of help.
And so we really, really appreciate this first launch back into in-person with in-person questions and in-person answers. So thank you guys so much.